Okay, this is going to be the surgery guidelines, which there's very few of them, and then the integumentary system. That's what this video will be. So starting with the surgery guidelines of your 2020 CPT, we've got our green guideline pages. In the 321 coded book, this is chapter 12. The first of the chapters spends 4, 5, 6 pages on surgery guidelines, global package, lots of good definitions on all of that. So I would very much recommend that you read the wordy stuff in the chapter. Let's look at some of these guidelines. So here's the CPT Surgical Package for definition for surgery. The surgery section of the CPT is going to be all of your green tabs. Well, actually, that's not true. It's all of your organ systems. So your green tabs, your organ systems, is what surgery is actually on. Some of your medicine section also will have actual surgical codes, because that's kind of a catch-all section. So here's the definition. So what is included in a surgical package is what's listed here: your evaluation and management, local infiltration, digital blocks, topical anesthesia bundled in, immediate post-op care, dictating, talking with the family, all of that's in, writing of the orders, evaluating the patient post-anesthesia recovery, and then your typical post-op follow-up care. So that's what's bundled in a typical surgical package. Supplies and materials. You would never code additionally for supplies and materials unless they are over and above what is usually used for that procedure. Separate procedure. We're going to have some examples of separate procedure coming up. What the definition of a separate procedure, if you were to see the word separate procedure in a parentheses in a code description, what that's telling you is do not code this if it is inherent or was done at the time of another surgery, unless it is separate and identifiable. So most of the time, your separate procedure codes, that's the only thing being done at that time. Chances are that separate procedure code is going to be bundled in a bigger surgery, what I call the big dog surgery, and your separate procedure would not be coded in addition. That would be considered unbundling, and that's a huge no-no. Your unlisted procedures, I talked about this in the anesthesia video. Anytime you use unlisted, they're kind of a catch-all, so you could not find that specific procedure in an itemized or specific code, so you use an unlisted, and it must be accompanied with a special report from the physician. Okay, so that's one of the rules for that. Let me go back to separate procedure real fast, because this is what it's telling you up here. If you do happen to code a separate procedure code along with another procedure, and it's authentic, it's not unbundled, it was really done and is not included in the procedure, you would need to use a 59 modifier. And that's what it's telling you. And then that would get you through your NCCI edits. I kind of make a list here. Like I said in my anesthesia video, sometimes I go and write stuff. It's not that I don't understand it or it may be somewhat redundant and obvious. But sometimes I do, just to remind myself, hey, this stuff's bundled in, or this stuff needs to be remembered when I'm in this section, or something like that. So I have written down some of the main things that at the time of surgery, any surgery, if these things occurred, they're always going to be bundled in. You wouldn't want to code separately for them. And it's stuff like prepping of the site. So if you're having abdominal surgery, all the prep of that site would be bundled in. IV access. You have to have an IV to be able to have surgery. Sedatives that are given if they're given by the provider. Any local, topical, regional anesthesia. Remember, always your local is bundled in and topical. Always, always. You never code for that. Lysis of simple adhesions. This is one that you really need to think about. So say you're having abdominal surgery. The patient, it's the third time that they're going in the abdomen. Chances are there's going to be some adhesions. So that means those membranes have already been disrupted once or twice or three times. And so when they go back together, grow back together, mend, repair, they might become fibrous. They might become attached to other membranes that isn't normal. So the doctor has to free. Lysis means freeing. They have to go in and free the quote adhesions to be able to get to wherever they're going. If they are simple adhesions, that is not billed separately. If they are complex or really are contributing to the complexity of the procedure, adding time to the procedure, something like that, then you can see about coding them. But if they're just simple, the doctor documents, I lysed adhesions, and then the appendix was clear to slide or something, you're not going to code extra for that. Cultures that are done of potentially anything during surgery, anything irrigating of the wound, that is something normal in surgery usually. Extensive undermining, which is cleaning out of tissue, is over and above. Extensive irrigating, having to flush stuff multiple times, that isn't necessarily normal, but irrigating of wounds is normal. Insert and removal of drains. So patient has gallbladder removed and they insert a JP drain or something. That's all part of the surgery. Pulling it out will be part of the surgery too. Closing of wounds, cutting in of skin, to get incising to get to wherever they're gonna cut on. That's all part of it. Post-op dressing changes and all of the surgery supplies. So that's just kind of in a nutshell some of the basic stuff that's always included. So as you read op notes, maybe have this and you won't be caught unbundling as much. There are very few actual surgery codes. It's kind of one page or 1.5 pages. They're mostly fine needle aspirations, biopsies, and then we get right into integumentary. So that was kind of the end of the surgical guidelines, which apply to everything. Other guidelines, of course, we're learning are these blurbs that they put in to help explain, like this blurb and this blurb. So you always read those. So as we work through the skin section or integumentary section, I'm probably going to stop and then look up some codes, kind of do some practical examples, so that by the time we get to the end of the integumentary system, not only have we had an overview of most of the sections, we've also been able to look up some codes, see how the codes are applied. So there won't be a separate video for these coding examples either. I just think it's easier to just do it as we're going through instead of a whole separate one to drill down. We might have a drill down later on, but right now that's probably what we're going to do. So looking at the integumentary system here starts with skin, subcutaneous, accessory structures. And you can kind of see we have introduction and removal. Remember I told you anytime it is an introduction section or an other procedure section, it's a little bit of a catch-all. So these in here are just kind of some of that weird stuff. So image guided fluid collection. Placement of soft tissue location devices. This is like wires, seeds, clips, that kind of, they're just kind of weird stuff. Then we get into our incision and drainage. So that means maybe you have an abscess on the back of your hand. So they're going to incise, cut in, and then drain it. A single aspiration of an abscess, maybe with a needle, something like that, is a 10060. I always put single aspiration. We have simple and complicated. Now we're really, in all the videos, going to start drilling down to, okay, I have two codes here, 10080, 10081. They're both incision and drainage of a pilonidal cyst. What makes them different? Well, one is simple and one is complex. I underline, you'll see throughout. I'm very consistent with that because I have to be able to code accurately. I underline those differences so that I can very rapidly say, whoop, these are different. So what does my documentation tell me to code? Debridement. This would be debriding of infected or damaged tissue. I do want you to make note over here, code 11010. That is debridement specific to open fracture or open dislocation. So underline that. You would not use that code unless your scenario or your documentation had foreign material at an open fracture or an open dislocation. Your paring and cutting, this is very, very specific to the technique that the doctor uses. Very, very specific. Your doc will probably give you paring because that's the action that they're doing. So this is generally paring off of corn calluses, that kind of stuff. Okay, so let's stop there. And let's go backwards and let's do a little drilling. Let's do some examples. So our scenario is complex incision and drainage post-operative wound infection. So where do we go? Post-op incision and drainage. So incision and drainage is our action. We have that section. So now that we're at that section, what does it tell us? So we know it's going to be complex. And it's a post-operative wound infection. So hopefully we're going to be able to find a code that we can plug a lot of that information into. So this is acne surgery. That isn't going to work. Incision and drainage of abscess. Well, hopefully we can get a little bit more specific and get a post-op wound infection, something like that. Up here, incision drainage, removal of foreign body, that's not it. Incision of hematoma, that's not it. Puncture, aspiration of abscess, that's not it. Incision and drainage, complex, so we're putting that in post-operative wound infection. So there it is, 10180. Post-operative wound infection implies it's during the post-op time, global period. So you would put modifier 78, unplanned return to operating room by the same doc following initial procedure for a related procedure. So our scenario doesn't tell us it was a different doctor, so we're going to assume it's the same doc doing the follow-up post-op care, and there's a post-op infection that they have to go back to the operating suite and fix. So that would have a 78 modifier. Okay, next one. Incision and drainage of hematoma skin. So the skin part's telling you how deep. So it's not a hematoma of the muscle. It's hematoma of the skin. Incision and drainage. So we're still in our action place. So incision and drainage. Now we have to find the one that's hematoma. So that's over here, 10140. Incision and drainage of hematoma. Okay. Let's do one more. Simple incision and drainage of 5 infected cysts. 5 infected cysts. So Here we go. This is acne surgery, incision and drainage of abscess. So infected could be an abscess. So let's look at our parentheses. Carbuncle, suppurative hidradenitis, cutaneous, subcutaneous abscess, cyst. Simple or single. So I would, if I were you guys, I would underline that simple or single. And then the next one is complicated or multiple. So we have our incision and drainage. We have our cyst. We know that there were 5 of them. So we would use code for multiple 10061. Okay? So now let's get further in the book. We have done, here's our biopsy section. They've really added into this section. So I would take a little bit of time to read the difference in the different biopsies, just so you have a better understanding. If you're coding out of this section, anytime you see a little table like this, I would code from this table, period. Code from the table. It kind of takes some of the thinking and complexity out of it. Great pictures in the CPT to kind of give you an understanding of what a punch biopsy is. Different skin biopsies that they might have. Here's removal of skin tags. That section is very, very, very specific to skin tags only. Shaving of epidermal or dermal lesions. So epidermal and dermal, that's just telling you depth. So if you know your skin, so you can go back to this picture. Here's your epidermis. So epidermal would be just that very, very top layer, and it doesn't have any blood feeding it. There's no blood vessels in it. And then your dermis, and then your subcu. So this tells you the different layers. Really good illustration of that. So this would be specific to the technique of shaving. So that would be fairly easy to get into. Now let's talk about removal or excision of lesions, whether they're benign or malignant. They are divided. Benign and malignant. This section is divided. Both of them have the same rules. So as you're reading your guidelines, for both of them, they include a simple closure. So if a doctor has cut into you, taken out a lesion, and sewed you up one layer, that's bundled in. If a doctor takes out a lesion and has to sew you up with 2 layers or 5 layers or 10 layers, that's an intermediate closure and would be coded in addition. So really make sure that they're going to get you on the board or try to get you. Make sure that you understand that simple closure. If they cut you open, they're pretty obligated to sew you back up. But the only kind of sewing up or suturing is your simple, your 1 layer closures. Let's talk a little bit about margins and how you go to determine the size of a lesion. So I do have down here how we calculate margins. And your margins are calculated by two things. One, what is the widest part of the lesion? So here, the doc is telling you that this lesion is 0.9 centimeters. So this red part is the lesion. So it's 0.9. The doctor is then telling you, so the next part of it, so that's the widest part. So going horizontal is not the widest part. So this vertical is the widest part, 0.9 centimeters. Then you take the narrowest part of the margins, times them by 2, and then add the 2 numbers together. So the narrowest part of the margins, so here we have documentation of 0.3 centimeters as a margin, 0.3 centimeters as a margin. So the narrowest part, we don't have more than one number, is 0.3. We have to double that to 0.6. And then we add that to the widest part of the lesion. So here's your equation. We have 0.9 for the widest part of the lesion. 0.6 is our margins that we've doubled. We've taken the smallest part and doubled it, added them together, and so you have a 1.5 centimeter lesion. And that's the number that you would plug in to then get your lesion code. Let's do another one. Here's a melanoma. One thing to know about melanoma is they're probably always going to take what they call as a wide excision. So instead of just going a little bit around, here's the small lesion, but they're going to go wide around to make sure that they have every single cell of that melanoma that they can, because it's such a bad type of skin cancer to have. So let's look at this. So they're telling us the widest part of this lesion is 1.0, 1 centimeter. Then they're giving us the margins as 2.0. So that is double the size of the melanoma, which would be normal for a wide excision. And again, 2.0 here. So we take the narrowest margin, which in this scenario is 2.0, double it to 4.0, add that to the lesion, which is 1.0, and we get 5.0 centimeters, which is what we plug in for our code. A melanoma would be malignant, so you would be actually getting this code from your malignant section. If this ended up being a malignant code too, is what they gave us. This one's benign. So this 1.5 centimeters would be found in the malignant as well. If they give you benign, you code it to benign. If they just call it a lesion, then you assume it's benign. Do not ever assume that it's malignant or cancerous without the documentation to prove it. So let's do this. This is an elliptical cut. If you see that in your op reports, that's what that means. It looks like a sideways cat eye, or that's how I think of it. So here we have a benign lesion, and we're going to take the widest part, which is 2.0, the widest part, and then we have margins of 0.2. So we're going to double those. And it's telling you here, they're actually giving you more, they're doing the 2 by 1. So when you have this, so they're saying this is 2 centimeters and the width of it is 1 centimeter. So that's a good example of always taking the wider part. So out of the 2 by 1, you take the 2. You have 0.2 for your margins doubled, which is 0.4. So you're going to add 2.0 plus 0.4, or 0.2 doubled. So your whole number or size of your lesion is 2.4. That's what you would plug in for your benign lesion. Okay, if you look at these codes, they're divided up by body groupings. So if you look at code 11400, this is a benign lesion, no skin tag. It says except skin tag. If you have a skin tag, you go over here to skin tags. And the body parts or grouping for 11400 and the indented codes underneath it is trunk, arms, legs. That's it. So then let's follow the indented. So 11420 is our next not indented code. So this is the same excision of a benign lesion, but a different body grouping. Scalp, neck, hands, feet, genitalia. And then indented codes. The indented codes divided up by size. So once you get to whether it's benign or malignant, then you get to your body grouping. All you do is plug in that size and that's your code. Okay, and then that's how your malignant lesions follow the same rules. So let's stop here and do a few examples of malignant lesions. So our first example, let's do physician excises a 1 centimeter benign lesion, left forearm, defect is closed with simple closure. So first of all, is it benign or malignant? It is benign. So we're in here. Then find your body part. So it's left forearm. So we need to find the body grouping that has arms. So 11400 has arms. So we're under benign. Now we have our body part. Then we have to find our size. So the doctor gave us 1 centimeter. He did not give us margins. So we have to assume that the margins are already in that 1 centimeter. So I'm just going to plug in the 1 centimeter. So code 11401, excised diameter 0.6 to 1.0, and that's your code. So 11401. Okay, let's do another one. Excision of a 2.0 malignant lesion of the nose. Oh, we might need to write this down. This has multiple. So let's do this. This is how I would do it. So excision, so we have a 2.1 centimeter malignant of the nose. So that's my pertinent information I need to know. Then we have 2 malignant lesions on the chest. So we have malignant chest, 2 of them, and they are each 1.5 centimeters each. So we have a total of 3 lesions that we're going to be looking at here. Looks like they're all malignant, so that's where I'm going to go first. So I'm going to go to my malignant lesions. Let's do the nose first. So the nose, so I'm under malignant. I have to find my body part. So here is trunk, arms, legs. That's not a nose. So I keep going. Here we have scalp, neck, hands, feet, genitalia. Still not a nose. So I just keep going. And 11640 is a face. The nose is on the face. It also does list nose, so I'm going to underline that. And I have 2.1 centimeters, so I got to go indented under here. So 11643 is that code. We're going to talk about sequencing these in just a minute. So now I have my nose code. So now I need to go to my chest and then find these 2 codes. So I go back. I'm still under malignant, so I go to my chest. Trunk is anything not arms, legs, and head. So trunk would include a chest. So I have 2 lesions on the chest. You don't ever combine lesions. They stand alone. So 1.5, 11602 for both of them. So now what do I do with this? What am I going to do with this? So how we sequence, we have the codes now, but how do we put this all together correct? And do we need modifiers? So I would do your most complex procedure first. In lesions, it's the bigger one. So I would code first my 11643, comma. That's my biggest one. Now I'm done with it, so I'm just going to mark it out. Now I have 2 on the chest, equal size. What do I do with them to get them paid? Because I want the doc, he had to make separate incisions. These are standalone malignant codes. So my code is 11602, and I'm going to put a 59 on it because it's separate, distinct, and identifiable, comma. And then another 11602-59. So that 59 is going to pull them out, save them from the NCCI edits. You have documentation. You had 3 separate lesions in separate, they may both be on the chest, but they were in different places on the chest. They weren't in the same place on the chest. There were 3 separate incisions for that. So that's how I would write it. That's how we're using modifiers. So this is kind of helping us learn how to use those modifiers too. Okay, so let's do another. Let's get out of this and, well, no, let's do one more. Let's do one more lesion. And let's remember again what type of closure is bundled into lesion excision. Simple closure. If they closed, and we'll learn about closures in a minute, if they close the incision with one layer, it's bundled in. Okay, one more for lesions. Physician excised a 2 centimeter benign lesion of the face. So we're benign. So now we have to find our face. So we have trunk, arms, legs, follow down. We have scalp, neck, hands, feet, follow down. We have face. So this is where we need to be. So we're benign. Now we have our body part. Now we just plug in the size. The size was 2 centimeters. Here's 2 centimeters. 11442 is your code. See? It's not so hard once you break it down that way. You just have to take your time, gather the information you need, and then plug it in. And always read very critically and detailed. Okay, let's do something not in here. Let's look at some biopsies. So the biopsy section, let's do one from in here. Punch biopsy of a benign skin lesion on the back and another one on the arm. So we have 2 body sections, 2 body areas, but it's a punch biopsy. So we go to that punch biopsy section. So here we are, punch biopsy section. Here is where, see how they have the different biopsies. You might even want to do that. Underline the different biopsy, and then your eyes will see how they change. So this is where punch biopsy starts. So our scenario is punch biopsy of benign skin lesion on the back, another on the arm. So 2 body areas. So punch biopsy of skin, simple closures included. So it's not dividing up the body section, the body organs, so, or body areas. Sorry, I'll get that right in a minute. We have 2 lesions. So down here is an add-on code for each separate additional lesion. So we would code 11104 for the first lesion, and then 11105 for the second lesion. And that's how we would code that. Okay, let's do one thing with the pairing, just so we've seen that code before. So here's our pairing section. Our scenario, 4 warts were removed by pairing. So pairing is that piece of information that gets you to the right area. So we're under pairing, and we want 4 warts to be removed. So here it's pairing or cutting of benign lesion or hyperkeratotic. They give you examples of corner callus. Because we used pairing, wart would be acceptable in here too. We have 4 of them, so you're going to use code 11056 for 2 to 4 lesions. Okay? See, we're already getting the hang of it. Okay, let's get past our malignant lesions. We go into, you have your nails section in here that you turn the page. I do have a note here because I always forget this. I'm not a great rememberer of modifiers. My money modifiers I do pretty good with, but I forget my left, rights, and my nails. So remember, you have the HICPICS modifiers down here for toenails and fingernails. So that would be going on your codes. Pilonidal cyst, very, very specific to that type of problem. So that's a fairly easy section. Your introduction section, remember, it's always the catch-all. So kind of look in here. This is different injections, tattooing, tissue expanders, just kind of some weird stuff like that. Now we're into our closures. This is closing of the skin. Make sure that you read the difference in a simple, intermediate, and complex repair. So a simple repair in a nutshell is sewing up of the skin one layer. They cut you open, they sew you up on top of the skin. That's a simple closure. Intermediate repair is layered, a layered closure. So if they cut you open, had to sew up the fat and then sew up the skin, that's 2 layers, that's now intermediate. Maybe they cut your thigh open and it's got a lot of layers and they cut deep. So they have to sew up maybe 3 layers of subcutaneous or the fat and then the skin. So that would be 2 or 3 or 4 layers. That would be intermediate. Your complex repair is more than layers. And it gives some really good guidance here, more than layers. So the caveat to these areas, how they can switch. You can have a simple repair, and it tells you here, single layer closures that are heavily contaminated. So say you have a gash or a laceration, and it's covered in oil, motor oil, or covered in some type of grease or some type of solvent or something like that, that you don't just clean it and it goes away. Something that a wound that is heavily contaminated and requires extensive cleaning, not irrigating out and not done in just a few seconds, but something that might take 15 or 20 minutes to even get clean before they can sew you up. That's what you're talking about. That simple closure would become an intermediate because of the time factor, the skill factor. You do, under complex, have some very good guidelines on when to claim this complex repair. One that is pretty commonly seen is a scar revision. If they're going in and doing a scar revision, that's probably going to qualify as a complex repair. So then, now we have our areas of simple, intermediate, and complex. You find your codes just like we did in the lesions. You find your body part, get under the right kind of repair, then find your body part, then plug in your number. That's how it kind of flows. Okay. Adjacent tissue transfers. This is another area that you have to really, really read the guidelines and know them. The CPC board will try to trip you up, just like you had to know without a shadow of a doubt that your simple closure was bundled into your benign lesion. You have to know that if you claim a code out of the adjacent tissue transfer, the excision of a benign lesion or a malignant lesion is not separately reported. And you will have this on the board, so know it and understand it, flag it. If they excise a benign or malignant lesion by way of an adjacent tissue transfer, do not code the excision of the lesion, code only this, because the reimbursement for this code includes that excision. You may also need a 58 modifier here, not on every time, but if you are doing something staged, your 58 is a staged. Perhaps there's different defects that it's going to take 3 times to get it sufficiently, or has 3 stages to get it sufficiently corrected. Then you might need a 58 modifier. Skin replacement surgery. We have a lot of guidance on this. This section used to be 5 or 6 pages long in the CPT. They've condensed it pretty well. I do, just like a lot of other redundant information, I do put some definitions down here just to kind of rapidly remind myself. So if you see an autograft, that means it's coming from you, the patient. Came from your own body, going on your own body. Xenograft comes from a different species, like a pig. Allograft comes from a human, goes into a human, but they're different people. So autograft is human to human, they're their own person. Allograft, person to person, different people. Good guidelines in here. Good wordy stuff, good terms in here that are defined. You want to understand autologous and non-autologous type of words. If you have a potential question on a quiz, exam, the board that talks about skin grafts, probably very much worth your while to come in here and look at the guidelines. Hopefully you've already read them and underlined the important stuff so you could rapidly get to them. Surgical prep site or surgical preparation. This again is dealing with grafts, skin grafts. This first code, 15002, is the recipient site. That is the site receiving the graft. Conversely, you can have other codes, 15200, that's talking about a donor site. So know that you have recipient sites and you have donor sites in here. Surgical prep is this area. Then you get into autografts. So kind of highlight or underline these different sections. Your autografts are all together. Your skin substitute grafts are together. And that's all the grafts. They've done a very good job of condensing them. Flaps, skin flaps. There's defects that have to be removed that they use a flap to cover. One of the more common ones, say something happened and you had a defect on your thumb. They can pull skin over to cover it, and that's called a thenar. That would be a thenar flap. Your other flaps and grafts is just where they've thrown that weird stuff that there wasn't a place to put it earlier in the book, and they just kind of throw it in there. It really makes these sections more difficult. So I sit and kind of read through, not that I'm going to remember it, but the more times that I glance through it, maybe if I'm looking for something, it'll trigger my memory. Hey, I think that was in that weird place. And that's probably where it is this weird place. Then we have other procedures. Remember, introduction and other procedures are your catch-all sections. They have just kind of weird stuff in it. So other procedures here has dermabrasion in it, chemical peels, removal of excessive redundant skin, maybe after gastric bypass a year later, something you have a lot of extra skin. This is where that excessive skin would be removed. Paniculectomy, that's a very common procedure to code from in here. Okay, so let's stop right there at pressure ulcers and let's code a little from this section. So I'm going to go back to where we started. Let's get a little bit in this introduction section. So patient presents for a subcutaneous implantation of estrogen or estroidal and testosterone compressed crystalline pellets. So we're going to have implantation of pellets. So let's see what we can find in here. So injection, tattooing, sub-Q injection, removal of capsules, that's a removal. So here we go, 11980, subcutaneous hormone pellets, so estrogen and testosterone are hormones, implantation. So that's our code, 11980. So it's just kind of a weird code. Let's do a sub-Q or fat injection of 15 cc's of collagen. So we need an injection code. So that's for lesions, tattooing, subcutaneous injections of filling material, and it gives us collagen. So now we need 15 cc's. So I'm going to go down here, over 10 cc's, 11954. Awesome. So that's the different stuff that's in here. So now let's do some closures. Closures are big. We've only got a couple more sections. I know this is kind of a long video, but I think it's going to help, and you guys can leave comments if you would rather me do a separate video to using the codes, the practical, or if you like it that we stop and we practically see how to use the codes. You can let me know. I'm sure you will. Okay, so repair codes. Let's do a little bit of coding. Oh, one of the notes, and I didn't say this coming the first time, stuff that's already bundled in. So remember, unbundling is a huge no-no. So your local anesthesia is always included. I've said that probably 5 times now. Simple ligation. So if they're cutting something open and there's something that just kind of keeps bleeding and they need to tie it off, that's a simple ligation. That's going to be bundled in too. Now, if you've got a huge laceration and there's 15 bleeders, that's probably not simple anymore. But just a simple laceration that has 1 or 2 places that are bleeding and need to be tied off, ligated, that would be bundled in. Also, nerve exploration. So if you see an op report of the hands, anything, if it's cut open, they're going to want to make sure all the nerves are intact. So exploring that and determining that they are all intact or not, that's bundled in. The nerve repair may not be, but the exploration to figure out the integrity of the nerves would be. Okay, so let's do simple repair, 3 centimeters scalp. So first, go to your repair. So it's a simple repair. Then your body system. So it's scalp. So let's look here, simple repair, scalp. There it is, just sitting right there looking at me. 3 centimeters, 12002. Okay? This is another guideline issue. I'm going to read this to you, and then I'm going to show you where in the guidelines the answer is. A physician performed a 4 centimeter wound closure on an established patient using adhesive strips. This is like butterflies. Adhesive strips during a level 2 E&M. So if you look under your guidelines for repair, you would see wound closure utilizing adhesive strips, so that's butterflies, as the sole repair material should be coated using the appropriate E&M. So if you don't know that guideline, you're going to go start looking in simple closure, 4 centimeter, and give him a closure code, but it's actually an E&M code. So the scenario gave you a level 2, so that would actually be a 99212, established 99212, and that's what we would code. Okay, let's do another one. Let's do intermediate closure of the thigh, 3 centimeters. So intermediate, find your body part, thigh. So this is trunk and or extremities. So thigh is an extremity, 3 centimeters. So this is 2.5 or less. So 12032 is your 3 centimeters. It's in that range. Yay. Okay, let's do a skin graft, just so we've gotten in here. Which one do I want to do? Let's do a full, sorry, I had to think where my mind was. Let's do a full thickness skin graft, free. It includes direct closure. So here again, I would have to be writing this stuff down, or if I were looking at it, underlining it. So so I need a full thickness. I need that to know what code. It's free. I'm probably going to need that word. It's going to include, and like I said, you would be highlighting this if you were looking at the actual scenario yourself or underlining yourself. You wouldn't have to rewrite it. I'm just doing it for the video. It includes direct closure of donor site. Hope you can read my writing. Body part is trunk. 20 square centimeters. Surgical prep. Oh, there's a second one. Whoop. So we will be doing a surgical prep. So this was the donor site. So this is a donor. Make sure we label this right. Surgical prep, this is going to be the recipient. Ooh, hope I spelled recipient right. It'd be terrible. Okay, so surgical prep of recipient site trunk, 20 square centimeters. And they were all performed at the same time. So these are the two things we're looking at. So let's find the codes first, and then we'll see potentially, it's probably going to be this full thickness skin graft that is more complex than just preparing a site. This is probably going to be our recipient site code. But let's find a full thickness first. So donor site, so this is coming from the same person. They didn't tell me it was another person. So I'm going to assume this is an autograft. One site to the other, same person. So let's find, so I'm under autograft. Let me find full thickness. So here starts my full thickness. So you might want to go through here. Here's a split thickness. This is epidermal autograft. See, they're just a little different. Here's another split thickness. See how this is a dermal autograft, not an epidermal. Okay, so here starts our full thickness. So we know that we're right. So we've got our full thickness now. We wanted to include direct closure of the donor site, and we want free. So this is a full thickness graft, free, including direct closure of the donor site. So we're doing good. Our body part is a trunk. So we've got trunk, and our size is 20 square centimeters. So 15200 is that code. You see, you would add on, say this was 40 centimeters. If we change this to 40 centimeters, then you would use 15200 plus each additional 20 centimeters or part thereof, 15201. So then we would add that code on. Now let's do surgical skin prep. So we're under surgical prep. This is of the recipient site. Trunk 20 square centimeters. So let's see here. I have notes that this is prep of the recipient site. Surgical prep of recipient site. Trunk first 100 square centimeters. So this is the code we need here, 15002. So the actual graft would sequence first, that's more complex, and then you would code your surgical prep. Yay, that's good. Good stuff. At least we got a graft done. Okay, let's talk a little bit more. We just have a few more sections of the integumentary left, so we're doing pretty good. The destruction section. Oh, no. Pressure ulcers. One thing to note, your pressure ulcers, and this is my note, adjacent tissue transfers that are done at the time of fixing a pressure ulcer are bundled into this code. You would not code additional for those. And there, you've got a guideline that tells you that. Your adjacent tissue transfers are over here. Remember, what's bundled into them are the benign and malignant lesions. Pressure ulcers are not bundled in. These are actually bundled into the excision of a pressure ulcer. That's the only way to fix it. If you have a pressure ulcer on one of your butt cheeks, they cut out the pressure ulcer and then they pull the skin over to close the defect. That's very simple way of explaining it. It's much more complex depending on how involved the pressure ulcer is. But that's a little bit of the thinking behind the adjacent tissue transfer being bundled in, because that's kind of one of the only ways that they can fix the defect. And the pressure ulcers can be very deep. They can be infected. They can go all the way to the bone. There can be lots of complex factors in them. So there's a lot bundled into these codes in order to fix those defects. Destruction codes. These are codes, all of them are destruction codes. So there's a chemical, there's heat, something completely destroying them. When you cut something out, you have that to send to pathology. You have a piece of tissue. When you destroy something, nothing goes to pathology unless they do a representative biopsy first. So say I had a big lesion here that they were going to burn off, destroy it, burn it. They might take a representative biopsy, send it off to pathology so that we know what it was. Then they would destroy it. So it'll come back, if it comes back malignant, it was destroyed. If it comes back benign, it's still destroyed, but maybe you feel better because it wasn't really cancer. So that's what this section is. This table very much gives you the rule of nines on burns. This is really a good table for burn estimation, whether it's babies, toddler, pediatrics, or adults. A couple of things to look at in here. Code 17,000. I always have to underline pre-malignant, so my eyes see that. Actinic keratosis is probably your most common one in here. And then I have to underline on the add-on code, your 17003 each. So for the scenario to use these, say your scenario, doctor removed 5 actinic keratosis from the patient's arm. So doctor destroyed, so we go to destruction because we're under the right area. Actinic keratosis, so that's a pre-malignant lesion. He destroyed 5 of them. So code 17000 is your first lesion. Well, then you have 4 more to account for. So your add-on code 17003 is the 2nd through 4th lesion each. So you count them. So you would have 17000 and then 17003 times 4. So that you have 1 lesion and then the other 4 lesions. That's how you would use it. Now, what's different is 17004, say you had the same scenario. Patient comes in to have actinic keratosis destroyed, 17 lesions. You would use only one code because you have 15 or more. So this is a destruction of actinic keratosis, 15 or more. So we had 17. So you would use only 17004 for that scenario. Simple wart destruction, down here 17110. It tells you this is destruction other than skin lesions up to 14 lesions. So if you have 14 lesions or up to that removed, you have one code. If you have 15 lesions removed, it's one code, 17111. Destruction of malignant lesions. Same scenario. You have to find out, these were all benign or pre-malignant. These are malignant, same thinking. You have to plug in what the destruction is, and then either by size or body part. Let's talk a little bit about Mohs. Mohs surgery in a nutshell. You have a skin lesion that the doctors are going to remove a layer at a time until all the layers are, all the affected layers are removed. So again, I have a lesion on my hand. The doctor, I'm in the operating room. The doctor takes off one lesion or one layer of the lesion, goes and looks at it under the microscope. Yep, there's cancer lesions or there's lesions still there. So he comes, takes a second layer off, goes and looks at it. Yep, we still have bad stuff. Takes a third, still have bad stuff. Takes the fourth, all clear. There are no abnormal cells, no malignancy, none of the lesion is on that fourth sample. So that's Mohs in a nutshell. You kind of have the surgeon and the pathologist all together in one, and you just go layer after layer until you're completely clear of whatever the defect is. So how these are, if you see, you have two full codes, 17311 and 17313. The rest of them are add-ons. So the information you have to know, first you have to know it's Mohs. This is where you come. Second, you have to know your body part. And you can see each of these have a body part. Then you have to know, is it a first stage, second stage? And then of that stage, how many blocks? You can do up to 5 blocks a stage. So stage 1, 5 blocks, stage 2, 5 blocks. The doctor will give you that information. So your add-on codes, 17312 is actually additional stages after the first stage, up to 5 tissue blocks. So you just kind of piggyback and build. 17314 add-on code is additional stage after the first stage, up to 5 tissue blocks for this body part. And then the last add-on code would apply to any set of body parts, and it would be additional blocks after the first 5, any stage. Okay? And then this tells you you're going to use this add-on code 17315 in conjunction with 17311 all the way to 17314. Okay, now we're going to get into breast, and then we're going to be done with skin, which is really good. So overarchingly, something to remember. If your documentation says that an excisional biopsy was performed, you don't code the biopsy side of that, you code only the excision. So that's just something to know. Also, because the breast has mirror images, you're going to use a 50 modifier. So bilateral, if it applies. You have biopsies, you have ablations, You have different excisions of cysts. Your introduction section here is, a lot of it is a placement of breast localization devices. So they're placing something for further test, for surgery, something like that, for localization, finding stuff. Then you have your mastectomies. Remember, with your mastectomies, you need to track it either left breast, right breast, or both breasts, which is a 50 modifier. On your mastectomies, I have to do a lot of underlining in here. I got to know that 19301 is a partial or a lumpectomy. If they state that they have completed a lumpectomy, you will never use excisional biopsy for that. You convert it to a lumpectomy. That gets inaccurately coded often. Simple mastectomy complete, and then it just builds on your mastectomy all the way from radical to radical, including the lymph nodes, to a modified radical. And then you have different repair. This is repair of implants, maybe nipple reconstruction, inverted nipple repair, that kind of thing in here. And then and you will see this several times throughout the CPT. If there is a code from another section that might be used in this section fairly often, I make myself a note. So in this section, when they're diagnosing breast cancer or lumps, that kind of thing, they very often inject a dye to the sentinel node, and that's what this code is. So I put in here, may need to use 38792, injection of dye to sentinel node. And that just kind of helps trigger, and that's it for there. So let's do a little bit of example coding for the rest of this, and then you will have a good basic understanding of the integumentary system and how to use some of the codes. Okay, so let's do destruction of 17 skin tags. So where do you think we go? Remember, those skin tags are the funky ones. They have their own section. So we have to go backwards. We have to go backwards for these. So we actually find removal. And in here, it doesn't matter what form was used. We're destroying 17 skin tags. So code 11200 is up to 15 lesions. So we still have 2 lesions unaccounted for. So 11201 is each additional 10 lesions or part thereof. What that or part thereof means, it could be one of the 10 additional or 10 of the 10. So we have 15 and then 16, 17. So how this would be coded is 11200 and 11201. Okay, patient underwent removal of 5 warts. So remember where we wrote our warts? So patient underwent removal of 5 warts using a laser. Laser destroys. So we're going to come in here. We're going to see destruction, laser. We have 5 warts. So up to 14 warts is this code. So we would code that only 17110. Easy peasy. Let's do chemical surgery, 3.8 centimeter malignant lesion, scalp. So we have to get, so this is a destruction, but we need malignant, not benign. So I'm going to go over here to malignant. We did cryosurgery, malignant, and so I'm malignant. Now I got to find my body parts. So here's my scalp, and then I plug in my size, 3.8. So 17274 gets me malignant destruction of a scalp lesion. That's 3.8. Easy peasy. Okay, let's do a couple of breasts and then we are done. We've whipped this. Okay, my breast section. Let's do lumpectomy, left breast. Lumpectomy, left breast. Now remember I told you your lumpectomies will fall under mastectomy. They are never an excisional biopsy. So 19301 says lumpectomy. Did it give me what size? Lumpectomy, left breast. So I would code 19301-LT for breast, for the left breast. Remember, we use LT, RT, or 50s. Let's do another one. Physician performed a partial mastectomy of the right breast with right axillary lymphadenectomy and biopsy of the right sentinel node. Sorry, I said that disjointed. So we have a partial mastectomy. So I'm under mastectomies, starting at mastectomy. Here's partial. Right breast with right axillary lymphadenectomy. So here, mastectomy partial with axillary lymphadenectomy. And biopsy of the right sentinel node. So your biopsies, so I'm at 19302. Your biopsies done at the same time as definitive treatment generally are not ever coded, so it becomes bundled in. So all I would code is the 19302-RT for the right breast. Okay, let's do one more. Patient undergoes percutaneous left breast biopsy with placement of a breast localization clip under stereotactic guidance. So where do we start? So patient undergoes, so let's go back to the front of breast. Sometimes I have to go back to the beginning and then start my thinking more organized. So patient undergoes percutaneous left breast biopsy. So we're breast. We want a biopsy, so let me at least get there. So here, breast biopsy with placement of breast localization clips. So this is biopsy breast, placement of breast localization device, including stereotactic guidance. And I had said it was under stereotactic guidance. So this is the correct code, 19081-LT. Okay? All of this information that I've covered, you can find the wordy side of it in the 321 coded book, chapter 12. But this is it for our integumentary system. We've done pretty good. And musculoskeletal will be next, and I'll see you on the next video.